Dr. Mazen, you can share your presentation and start, please.
Yeah, Bismillah.
Just a test. Only one person. Welcome.
Is my presentation clear?
Yes.
Okay. Bismillah, assalamu alaikum. Good evening, everybody. I'd like to thank the panel for inviting me to this very nice scientific meeting and to be amongst such eminent speakers. Now, I'm going to present some cases in corneal tomography. Before I start, I'm going to tell how I'm going to go through this presentation. First, I'm going to show you how we can read systematically the Pentacam, the Cyrus, the Galilei, and the MS39, very briefly, in an easy way. And then I will present 11 cases of interesting corneal tomography cases. So this is the Pentacam, you know, the Pentacam, and this is the Cyrus, and this is the MS39, which is similar to Cyrus, but it gives epithelial thickness and stromal thickness in addition to stromal elevation. So it is just same maps, but it adds some other features. And finally, the Galilei. I'm going to start with the Pentacam in steps. And in each step, I'm going to compare it with others so that we can go all together with 4 systems. Now, usually, when the doctor is in clinic, usually we'll get this 4 composite map, which consists of the parameters on the left and the 4 maps on the right. The 4 maps are refractive maps, which are sagittal, anterior elevation, sagittal of the anterior surface, anterior elevation map, posterior elevation map, and corneal thickness map. Usually we get only this map for both eyes. Usually we don't get other maps, complementary maps. So I'm not going to explain the other maps. I'm going just to explain how the doctor can make a decision based on this available map. Of course, if a doctor can have an access to all other maps, it would be much better. Starting with KM, usually we look at the mean K on the anterior corneal surface. On the Pentacam, because it does not depend on Placido, so the cutoff value is 48 diopters. So the normal value should be less than 48 diopters. If we go to the Cyrus, it is just the same. We have to look at the average K on the anterior surface, but because it is Placido-based, the cutoff value is 47.2. And why this difference? This is based on studies, because in the Pentacam, it was based on Halliday report, which stated that 48 is the cutoff point, while here it is based on the Rabinovich studies stating that Placido-based devices should depend on 47.2. So since Galilei depends on the Placido as well, of course, the Cyrus and the Galilei, they depend on the Scheinflug as well. But I mean, they use the Placido in addition to Scheinflug. So similarly, in the Galilei, the cutoff value for the anterior average is 47.2. After that, we come to the sagittal curvature map. We have to look at the 2 opposing points on the steep axis on the 4 millimeter zone. So between 3 and 5 circles, it is the 4 millimeter zone. Now, the 2 opposing points, the difference should be less than 1.5 diopters if the inferior one is larger, and the difference should be less than 2.5 diopters if the superior value is larger. So this is applicable for all systems. So for the Cyrus, we have to look at the 2 opposing points as well, and we can use the same numbers, but we have to be sure that we are looking at the sagittal curvature map, because the default map in CIRUS, and of course the MS39, the default map is the tangential, not the sagittal. So if you want to study these numbers, you have to look at the sagittal curvature map. Similarly, we have to look at the sagittal curvature map in Galilei at the two opposing points on the steep axis or the vertical axis if you are not able to define where the steep axis is. Such in this case, we have inferior steepening only. So in this case, the two opposing point on the vertical axis, and you can use the same difference, but be sure that it is the sagittal curvature map. After that, we have to come to the central segments, red segments in the sagittal curvature map to check whether there is a skewed radial axis or not. You know the skewed radial axis, it's an angulation between the axis of the inferior segment and the axis of the superior segment. If the angulation is 22 degrees and more, it is abnormal. But of course, to be significant and to take it into consideration, the topographical astigmatism should be at least 1 diopters. Otherwise, if the topographical astigmatism is less than 1 diopter, we don't care about this skewed radial axis, even if the angle is more than 22 degrees. Now, this is in pentacam. What about CIRUS? In CIRUS, we don't have the segments. We don't see red segments on the sagittal curvature map. So we cannot guess whether there is angulation or not. So the method is to go look at the right of the screen. You can go to the K readings of the front, and when you click on the SIM-K, you can see the options that you can choose. You have to choose the hemimeridians. Hemimeridians means hemimeridians. Okay, so we click on the hemimeridians, as you see here, and then you choose the 3 millimeter zone. According to that, we can guess whether there is an angulation or not, such as in this case, there is an angulation between the two red segments in the 3 millimeters. So this is the only way in the CIRUS to check this skewed radial axis. This is another case, as you see, it is keratoconus, and you cannot guess the skewed radial axis. And if you click on the SIM-K, as you see, in the SIM-K, it seems that it is straight. While if you choose the hemimeridians on the 3 millimeters, you will find a very high angulation between the red segments. Unfortunately, in the Galilei, you can use neither of those two methods. So there is no there are no segments projected on the curvature map, and at the same time you cannot use the semi-meridians. So you have to draw it yourself, or you have to guess it yourself. Now we come to the other point, which is the corresponding point. And just a second, please, because of the noise. Now, we come to the elevation maps, and we look at the thinnest location corresponding to the, we look at the values corresponding to the thinnest location on the elevation maps. And we have to be sure that we are using the best fit sphere, 8 millimeters diameter for both anterior and posterior surface. So we look at those two values, and we compare them with the table that was put by Bell and Ambrosio based on the 3 standard deviation of the values in the normal population. We look at the spherical equivalent of the patient. If the spherical equivalent is myopic or equals 0, for example, if it is mixed astigmatism +2 sphere -4 cylinder, so the spherical equivalent is 0. So if the spherical equivalent is 0, or the spherical equivalent is in the minus, so the cutoff values are +8 on the anterior, +18 on the posterior. And for the hyperopic people, it is +7 for the anterior and +28 for the posterior. Above these values should be would be abnormal. After that, we come to the Cyrus. Unfortunately, we cannot apply those numbers on the Cyrus because they have their own method in evaluating the elevation maps. So alternatively, I use the Keratoconus risk screening available in the Cyrus and MS39. I look at the classification given by the machine. Of course, I do not depend completely on the objective evaluation of devices, but I can trust to some extent the evaluation of the Cyrus and MS39 in the keratoconus screening because it depends on the elevation maps and it depends on the tangential map. So in addition, in order to be sure that the classification is okay, you have to look at the lower corner. If you look at the bottom right, you can see that there is like placido rings on the cornea in the picture, and you can see a red circle. Now, this red circle, very briefly, it is the border. It is the border of the landmarks of many points, such as thinnest location, such as highest elevation on the anterior elevation map, highest elevation on the posterior elevation map, compared with the normative data, thinnest point in the relative thickness map as well, highest point in the tangential map. So all of these points are landmarks. So this circle is the border that gathers all those landmarks. Now, whenever the cornea is normal, those landmarks are discrete. They are here and there. While if we see keratoconus, you will find that this red circle is very, very small because usually the highest point on the curvature map is correspondent to the thinnest location, is correspondent to the highest elevation, and so on. So the circle will be very narrow when there is a keratoconus suspect or a keratoconus, such as in this case, as you see here. So this red circle is a good indicator that you are looking at a normal cornea or not. But however, there are some cases that are in between. So you have just to have an idea by doing this. Alternatively, on the Galilei, the elevation map is usually studied based on the best fit toric aspheric. And there is an index provided by the Galilei called the Asphericity Asymmetry Index, AAI, which usually looks at the posterior elevation map by the best fit toric aspheric, as I mentioned, and it measures the difference between the highest point and the lowest point on this elevation map. Now, if the difference is less than 22 microns, it is normal. If it is 22 to 33 microns, it is suspicious. And if it is more than 33 microns, it is very abnormal. We come then to the pattern on the cornea, which is, we just study the shape of the corneal, the thickness map. We don't study the numbers on the thickness map. So we look at the pattern, whether it is concentric or not. This is the concentric pattern, which is the normal pattern. Now, let's see the other patterns on the corneal thickness map. This is the concentric pattern, as I told you. This is the very normal one. And this is the horizontal displacement. Usually we see this in large angle kappa and in cases of misalignment, horizontal misalignment. And this is the dome shape. As you see, the whole pattern is displaced downward, usually temporarily as well. We see this usually in ectatic corneal diseases, but sometimes, or in many times, we can see this pattern in people having chronic eye rubbing, because the hand usually comes from down temporally. So this will distort the shape of the cornea and make it mimic the dome shape found in ectatic corneal diseases. So however, this is not a hallmark of ectatic corneal diseases, but it is a warning sign. And this is the droplet shape. Usually we see this shape when it is keratoconus and it is going to be pellucid marginal degeneration. I don't know who is drawing on my screen. Anybody is drawing on my screen? Very strange. Okay, so the droplet sign is a warning sign as well. Now we come to the other sign, which is the bell shape. We see as if it is a bell, because there is a band thinning in the inferior cornea, and this corresponds to the band thinning as we see it in pellucid marginal degeneration. This is a hallmark of pellucid marginal degeneration. This is the global shape, the globus shape, where the cornea is completely thin, extending to the limbus. Up to the limbus, it is very thin, globus shape. Now, these shapes can be applied exactly in Cyrus and Galilei. This is why I'm not showing those two systems in this regard. The final point is the thinnest location. We look at the thickness at the thinnest location. Remember these two numbers, the 470 microns and the 5 microns. Why? Because less than, in some studies, let's say, in some studies on a very large sample, the thickness less than 470 microns was found in less than 2.5% of normal people. So we can say that those who have less than 470 microns most probably are abnormal, most probably, because less than 2.5% of normal population have this low thickness. And however, we have to take into consideration the population, because in North Africa, the thickness of the cornea is less than this. So you may see 450 in very normal people. So you have to take into consideration the population that you are working with and you are treating. But this is based on Western studies. Now, we come to the MS39. The MS39, as I said before, it gives additional 3 maps, which are the epithelial thickness map, the stromal thickness map, which means that it is like, it shows the rest of the cornea without the epithelium, and the stromal elevation. As we know that we have anterior elevation of the cornea, which is anterior elevation of the anterior corneal surface, including the epithelium. And in MS39, it gives you the elevations on the stroma without the epithelium, which has its own interpretation, as we will see later in few cases, in addition to stromal thickness. Because the epithelial map is very important in refractive surgery, we have to understand the properties of the epithelium. The epithelium has a very nice property, and at the same time, it is insidious property, which is the filling effect. As you see in this case, we have very irregular surface under the epithelium because of a scar, and because the epithelium would like to create a smooth anterior surface of the cornea in order to smoothen the movement of the lid. So it fills the gaps. So it fills the valleys and it thins over the mountains. Now, this is another example. This is a case of intracorneal rings. Look at the shape of the cornea under the epithelium. This is the epithelium. Look at the thickness of the epithelium at the periphery to make the anterior surface of the cornea very smooth. Now, because of the masking property, we can understand what's going on under the epithelium. So we can understand the very early detection of keratoconus. Now, as you see, this is the epithelial thickness map in a patient having keratoconus. In keratoconus, because there is a protrusion of the cornea, the epithelium will thin over the mountains and it will thicken over the valleys. So as you see, this is the keratoconus and the bulging is here. So you see that the epithelium is thin downward and is thick above the cone. So it is thick here and it is thin here. This is the very common shape of the epithelial mapping in keratoconus people. There is another shape, which is the radial thinning of the epithelium. Whenever you see this flower shape or the radial thinning of the epithelium, then you have to suspect keratoconus as well, because usually the cornea, when it thins, sometimes it starts in the middle or the center of the cornea. Then the cone starts going downward because of gravity, and it takes the previous shape. But sometimes it starts like this, radial thinning. Now, this is a case of post-myopia treatment. And as you see, because it is post-myopia treatment and the stroma has been ablated in the center, so the stroma is flat in the center and steep at the periphery because it was myopic treatment. The epithelium, it tries to smoothen the anterior surface of the cornea by filling the center of the cornea by this hump, this mountain of epithelium. And this is one of the explanation of regression. Or it is, if we want to be very accurate, it is not a kind of regression. It is a kind of loss of effect. So the best description of this property is loss of effect of the myopic treatment rather than regression. Now, after this introduction, I'm going to show you 11 cases, different cases, to show you how we have to pay attention to every detail on the corneal tomography. Of course, we have to take into consideration the spherical equivalent if we want to read the pentacam, because in the pentacam, usually we use the table of Bell and Ambrosio for the elevation map, as I mentioned before. So this case, the spherical equivalent is in the minus, as you see in both eyes. And this is the pentacam. The pentacam of the patient is very normal, as you see here. The KM is 47. We said that the cutoff value is 48. Now, the difference on the anterior curvature map is 0.9, and the upper one is larger, so it is less than 2.5 diopters. There is no skewed radial axis in the central segments. Those corresponding to the thinnest location, the values are +4, +3, which are less than +8 and 18. You remember, 8, 18, 7, 28. And the pattern on the pachymetry map is concentric, and the thinnest location is 529. Now, according to the points that I mentioned, it is very normal. Now, this is a case, of course, of high astigmatism. Look at the astigmatism on the anterior corneal surface. It is 4.7, and for the posterior corneal surface, it is 0.9. So if you want to implant IOL, especially if it is toric IOL or premium IOL, we have to take into consideration this posterior astigmatism to avoid any surprises. In addition, look at the Kmax. The Kmax is 49.8. So no more, we are depending on Kmax. We don't depend on Kmax for classification of the cornea, whether it is normal or abnormal. I classify this cornea as very normal in spite of the high K reading, in spite of the high Kmax, which is 49.8. Now we come to the left eye. The left eye, very similarly, it is 47.1, which is normal. The difference is 0.2. The lower one is higher. And so it is less than 1.5. The skewed radial axis is less than 22 degrees. The elevation maps are normal. The shape on the of the corneal thickness map is concentric, almost concentric. And the thinnest location is 528. Now look at the astigmatism. It is 5 on the anterior and 1 on the posterior, which is very important to take into consideration for the toric, as I mentioned. Now look at the Kmax. It is 50.2 diopters. In spite of this high Kmax, this cornea is very normal. We come to case number 2. This case, I mentioned it a lot in my lectures as an example of bad capture. Let's say that initially, if you have this picture in the clinic, you may think that it is keratoconus. And you have the right to think it is keratoconus because, as you see, there is, let's say, steepening in the inferior cornea. There is bulging on the anterior curvature, anterior elevation, bulging on the posterior elevation, which is very, very high numbers, plus 34 or maybe more. And there is dome shape dislocation of the pattern of the pachymetry map. And, but this is misalignment. The patient was looking downward, and that was, we asked the patient to do this in order to get this picture for, let's say, scientific reasons. Now, this is misalignment, and this is the same eye after proper alignment. Everything disappeared. Very normal cornea, symmetric, no bulging, and everything's fine. So you have to pay attention whenever you see anything abnormal. The first thing to think about is misalignment during taking the capture. This is case number 3. Obviously, it is keratoconus. Why I put this? Of course, everybody can know that this is keratoconus, but I put this in order to make a definition of keratoconus. When to say this is keratoconus, because some cases are suspicious. We cannot say that definitely this is keratoconus or not. Now, this case is keratoconus because we have 2 things. The first one is abnormal sagittal curvature map, very abnormal. There is a skewed radial axis, there is inferior steepening, and the posterior elevation map is abnormal. So we look at 2 things, anterior curvature and posterior elevation. The posterior elevation is very abnormal, but be sure before reading the elevation map that you are using the best fit sphere, 8 millimeter diameter. Otherwise, you will get into troubles. So the corresponding to the thinnest location is maybe 40 or above. So we have 2 things, the anterior curvature, the posterior elevation, and it is keratoconus. We come to case number 3, which is pellucid marginal degeneration. In pellucid marginal degeneration, we have anterior curvature, there is a problem. Posterior elevation, there is a problem. In addition, there is a specific sign on the corneal thickness map, which is the bell sign. The bell sign because of the inferior thinning in the cornea and the bell sign. So the problem in the axial or sagittal curvature map is usually the crab-claw pattern, such in this case. So it is crab-claw pattern. And the posterior elevation is abnormal, and there is bell sign on the pachymetry map. So this is pellucid marginal degeneration. Now, in some cases of keratoconus, we find same crab-claw pattern on the anterior sagittal map, but we don't find the bell shape. So in this case, we call it pellucid-like keratoconus, and it behaves like keratoconus, not like pellucid marginal degeneration, because pellucid marginal degeneration, usually it starts later in age, and it usually progresses infinity. So it does not stop. We cannot say that at age of 50, the pellucid will stop. So the type of treatment will differ. Now, this is pellucid marginal degeneration. As I told you, this is the bell sign corresponding to the thinnest, to the band of thinning. This is case number 4. Now, if you look at the pachymetry map, very thin cornea. However, pachymetry map is not an indicator for anything except for pellucid marginal degeneration. Now, we have to look at the anterior curvature map. There is an inferior hotspot, and we look at the anterior elevation map. It is very normal. Posterior elevation map, sometimes we may look at the bulging, which is plus 25, as you see. It is plus 25. However, we have to ignore it. We have to look at the value corresponding to the thinnest location, which is plus 12. This is why I told you there are some suspicious cases which may be mixed with keratoconus. So this case is not keratoconus. Regardless of the refractive error that the patient has, this is the posterior elevation. And if the patient is myopic, the cutoff value for the posterior is 18. And if he's hyperopic, the cutoff value is 28. So in both cases, it is 12, so plus 12. So the patient, the posterior elevation here is normal. And since it is normal, and there is a problem on the curvature map only, so we call this paraectasia, which has 2 terms or 2 entities. The keratoconus suspect, which is not a suspect of keratoconus, when we say keratoconus suspect, it is not, or it does not equal suspect of keratoconus. Keratoconus suspect, it is this entity. We have problem on the anterior curvature map and nothing on the posterior elevation map. Now, the other eye has, as you see, two entities, as I said, the keratoconus suspect and the formed frost keratoconus. These two terms are under the umbrella of paraectasia. Now, as you see, this is the other eye of the same patient. The other eye has keratoconus, frank keratoconus. So we call this case as formed frost keratoconus. So we say this paraectasia, it is formed frost keratoconus when the other eye has keratoconus, as you see. So this is formed frost keratoconus in the right eye because the left eye has keratoconus. This is case number 5. We see that there is a problem in the curvature map. There is nothing on the posterior elevation map. So this is paraectasia. We have to look at the other eye. The other eye has the same problem. So it is keratoconus suspect. So we say keratoconus suspect when both eyes have the same, or let's say have problems in the curvature map, but the posterior elevation maps are normal. And if the other eye is normal, completely normal, it is called keratoconus suspect as well. So we call formed frost keratoconus only in one case, when the other eye has keratoconus. This is case number 6 on the Cyrus. Obviously, there is steepening on the tangential curvature map. Tangential curvature map usually comes as default in Cyrus and MS39. There is a protrusion on the posterior elevation map, if you look at the bottom right. So we will say that most probably it is keratoconus. Now we come to the pachymetry map, or the epithelial thickness map. This is on MS39. If you look at the picture in the middle, you will see that there is thickening above the center of the cornea, and there is thinning below the center of the cornea. I'm talking about the epithelial thickness map. So this is very specific to keratoconus, which is the thinning here is correspondent to the bulging on the posterior elevation. And okay, and it is correspondent as well to the hotspot. We can see it on the sagittal curvature map. This is case number 7 on Cyrus as well, MS39, let's say. As you see, there is inferior steepening on the tangential curvature. And there is a suspect, maybe because there is tongue-like extension on the posterior elevation. Now let's see. As you see here, there is no thinning in the epithelial thickness map. We see thickening. There is thickening in the epithelial thickness map over this hotspot in the sagittal anterior curvature. So this is false hotspot. And this patient has been using contact lenses. And immediately when he came to us, we removed the contact lenses, we took the picture, and we found this hotspot. If we leave the patient for 1 or 2 weeks without contact lenses, you will find this hotspot disappear. So it's very important to differentiate such hotspots from real keratoconus suspect or keratoconus by the epithelial thickness map. Now, as you see, there is no corresponding bulging in the stroma, in the stromal elevation. But what about this? Actually, this is a distortion. This is a distortion of because of large angle kappa, and most probably sometimes we can see such false hotspots in the sagittal curvature maps because of large angle kappa. This is case number 8. This patient had myopic treatment before. As you see on the tangential curvature map, we can see the center of the cornea ablated, very low K readings. And immediately after this ablated zone, which is almost 5 millimeters, you will find like a ring of high K readings. We call this contour effect. It's very important to put it in mind, the contour effect. The contour effect is a false appearance that occurs because there is a sudden change between the center, which was ablated, and the periphery, which was not ablated. So this jump, the computer or the software will think that this area, which is a step, similar to a step, will think that this area is high. So it gives it high K readings. So we call this contour effect, and it delineates the area of previous ablation. Now, this is not important in most cases, but it's very important when the ablated zone is decentered. As you know, one of the complications after refractive surgery is decentered optical zone. So in this case, you will find, I'll show you now later, some cases because of decentered optical zone, and you see that this contour effect may mimic ectasia. However, now this patient with this contour effect, let's say, lost some of the effect of the myopia because of the very thickening of the epithelium over the center, as you see here. This is case number 9. As you see, this is what I told you before. This is like decentered optical zone. It is decentered up. So the contour effect is down. And if you look at this picture, many doctors may think that this is ectasia after LASIK or after PRK. Now, this is the importance of the epithelial mapping. Actually, it is a revolution in the understanding of the refractive surgery, the epithelial mapping. As you see, look at the lower left, you will find the tangential anterior. You will find the contour effect. If you look at the bottom, middle bottom, you will find the sagittal anterior. Similarly, there is the contour effect. But look at the epithelium. There is thickening of the epithelium over this area rather than thinning. And you can see the corneal thickness map. It is very concentric. So there is no irregularity. There is no dislocation, downward dislocation. And look at the stromal thickness. The stromal thickness map is very concentric and very beautiful. However, there is a stromal elevation here, similarly to the contour effect, because of the decentered optical zone. So this is post-PRK contour effect in this patient. Now we come to case number 10. Now this case is very normal. The KM less than 48. There is no asymmetry. Skewed radial axis is less than 22 degrees. The elevation maps are beautiful. Regardless, let's say the patient, for example, has myopia, or hypermetropia, sorry. This patient has hypermetropia, and the anterior should be less than 7. It is obviously +2, and the posterior is +16 almost, which is less than 22. Now the thinnest location is 633. Look at the thickness map. It's very thick. And this is the left eye. The thickness map is very thick. Now I presented this case because actually we did not pay attention to the patient that he has Fuchs dystrophy until we did the endothelial cell count. So sometimes you may miss the appearance of the Fuchs dystrophy on the slit lamp. So you have to suspect the very high thickness of the cornea, and we found it Fuchs dystrophy. This is the specular microscopy. Usually in the specular microscopy, we have to look at 3 things: the endothelial cell count, the hexagonality, which should be more than 60%, and the CV index, which should be less than 40. So as you see, this is hexagonality is less than 60. It is 16 only, and the cell density is very low, and the CV index should be, sorry, the CV index should be more than 40%, and here it is borderline, as you see. This is the left eye. The left eye, the hexagonality is less than 60%, and the cell density is low, and the CV index is high. So again, I have to say the parameters of the endothelial cell count. We look at the cell count, and this depends on the patient's age, but it should be at least 2,000 at least. The second thing is hexagonality. Hexagonality, the normal hexagonality should be more than 60%, more than 60%. The CV index should be less than 40% in normal cornea. It should be less. If the CV is more than 40%, if the hexa is less than 60%, and if the cell count is less than 2,000, then it is abnormal. And it's very clear from the shape of the cells that it is Fuchs dystrophy. This is the last case. It is case number 11, as I think. Now, this case is corneal scar. Look at the curvature map. You will find there is like flattening at the mid-periphery, steepening in the middle. If you look at the posterior elevation map, you will find posterior bulging. If you look at the corneal thickness, you will find a very strange shape. But if you see the slit lamp view, you will find this scar corresponding to the flat area. So, and of course, there are variability of the tomographical shapes of the corneal scars based on the shape of the scar itself, whether it is circular as or spot, as in this case, or linear. There are different shapes. And in this case, this shape corresponds to the, or this scar corresponds to the flattening in the curvature map. And the bulging on the posterior elevation corresponds to the OCT. This is the OCT of the patient, of the cornea, and we can see the scar, which is deep scar, and there is a bulging on the posterior elevation actually, and there is a shrinkage in the whole thickness of the cornea in this area. This is why there is very much thinning spot on the corneal thickness, and there is posterior bulging, which is obvious on the posterior elevation map. So this is case number 12. There was maybe mistake by numbering. Okay, now this is case number 12. Case number 12 is to show you superior pathology in the cornea. Now, previously, like there was a thought that maybe there is a kind of PMD, which is superior PMD. It is like reversed, okay, upside down. So as you see, there is bell shape, which is the bell is up, while the as you see, there is like a Graphical, which is in the reverse shape as well. So this is not a superior pellucid marginal degeneration. Actually, it corresponds to superior pathology in the cornea. There is a superior pathology in the cornea. Now, because of this pathology, because of vascularization, because of the pannus, as you see, there are black dots here. Black dots means that the computer is not able to give correct information about this area, and we call this extrapolation. So the computer will assume these values based on the neighborhood values. But however, these values are not correct, so we cannot depend. So whenever you see any problem at the periphery of the cornea, whether it is superior, inferior, nasal, or you have to think about a pathology there. This patient had VKC, vernal keratoconjunctivitis. And that's it. Thank you very much.
Thank you very much, Dr. Mazen, for this wonderful talk and the very relevant topics you discussed. Thank you very much. I would like to ask the panel if they have any comments on this presentation.
Well, thank you very much, Dr. Mazen. I noticed that you pay attention to the anterior elevation and the posterior elevation. I noticed today that you focused too much on these 2 points today.
Yeah.
I mean, if there is like anterior elevation and posterior elevation, and there is no corresponding thinning, for example,
yeah.
think about this case.
Yeah. actually, if you don't have, if you see no correspondence between the maps, okay, so there must be an artifact or a pathology in the cornea. So you have to check the cornea.
Yeah.
In keratoconus, usually these things correspond to each other. You will find on the curvature map there is a steepening. You will find steepening on the anterior, or for sure the posterior should have steepening for sure, but the anterior not necessarily, because it depends on the stage of the keratoconus. And there must be a corresponding thinning of the thickness map. However, the most important mark is the epithelial thinning over the cone or over the hotspot that you see on the sagittal curvature map. If there is a corresponding thinning in the epithelial mapping, then it is real hotspot. Otherwise, it is false hotspot.
Yeah. What I mean is thinning, you know, is a relative thing. For example, if the patient had a cornea of 600, then becomes the cornea becomes 550, for example. It's still thick cornea, but it's a relative thinning.
Yeah, you're correct. This is why I mentioned that on the corneal thickness map, we don't look at numbers. We look at the pattern, whether it is concentric, it is dome shape, it is bell shape, it is globus. So this is why we look at the pattern, because as you said, there are cases of keratoconus with thick corneas, and there are cases of normal cornea, but thin cornea.
Perfect. Thank you very much.
Pleasure.
Dr. Mazen, I would like to ask about the new trends in managing keratoconus post cross-linking, and especially the PRK. So just I want to take your opinion about such treatments for cases that who want to get rid of the contact lens or the glasses.
Okay, great. Now, actually, let's say that, of course, it is a very long talk, and it has a lot of controversies, but I'm going to summarize everything, inshallah. The first thing is, we have to know that we are not treating refractive error. We are regularizing the cornea. So we have to concentrate on the comma and high order aberrations, okay, which is the irregular astigmatism. And we must not treat the sphere, because we are working on weak cornea in keratoconus. And even if we treat sphere, we may end up with hypercorrection. We are harvesting the stroma. We cannot give a guarantee for the patient that he will get rid of glasses. So no need to go into this. We have to regularize the cornea. This is number one. Number two, because we are regularizing the cornea, we are making gentle touch. So we have to be selective. We have to select the high order aberrations that we are treating if our machine is capable to do this. Otherwise, we have to treat what the machine suggests. We should not go beyond 50 microns of the stroma of ablation. Now, if we plan for cross-linking and for the customized laser vision correction, some people may say we have to do cross-linking first, we have to wait 6 months, and then we do the customized laser vision correction. Some people say no, we can do both together. I did both treatments, and I found that doing cross-linking first and waiting for 6 months is much better, because when we do the cross-linking, we will give a chance for the cross-linking to flatten the cornea, to get rid of some of the irregular astigmatism. Then we can decide for the gentle touch. Now, whether to go for wavefront guided or topography guided, there is a misconception amongst ophthalmologists. They think that if we go for corneal wavefront, we are treating wavefront. Actually, corneal wavefront is topography guided treatment, because it is based on elevation maps. The only wavefront, real wavefront, is the ocular wavefront. All right? So either we go for ocular wavefront, or we are treating topography guided treatment. Let it be topography guided treatment by wave light, or let it be corneal wavefront by Schwind, or let it be something else. And the ocular wavefront is by Vuzix. So, or technolus. However, I have no financial interest to go for ocular wavefront or to go for topography guided treatment. It depends on how much the cornea is distorted, how much you are able to get very good wavefront captures, ocular wavefront captures of the patient, because in distorted corneas, sometimes the information are not correct. In addition, if you want to treat a cornea with a cone, which is out of the 5 to 6 millimeters that the ocular wavefront can take, then you are doing treatment for something not really realistic. So as you see, it is something very controversial, but in all cases, we have to be very, very conservative. It is not a refractive procedure. We are not treating sphere. We must not tell the patient you have to, we guarantee getting rid of glasses or contact lenses. That's it.
Thank you very much, Dr. Mazen. I think I will take some question from the audience. I'll start with, with Dr. Ahmed Khalaf.
Hello, good morning. Thanks a lot, Dr. Mazen, for your enormous presentation as normal. Two questions I have. So the first, that some schools actually have the ideology that there's nothing called Keratoconus nowadays. And the second thing, in case number 4, you were saying that the elevation map not exceeding the normal, but for the anterior elevation, but in the 4 millimeter, there was a point that more than 25, and the left eye was more than 28. So do you, like, my question now is, should we concentrate on only on the thinnest point of the cornea, of the anterior cornea or the posterior cornea, or in the 4 millimeter where the operation will be? Thanks.
Let me start. Thank you very much. Let me start with the second question. If you want to take the zone of the 5 millimeters, then you are depending on the best fit toric ellipsoid, not the best fit sphere. So best fit toric ellipsoid, which is recommended by Jack Holliday, and it is mentioned in Holliday report in the Pentacam. So, sorry. Yeah. So if you want to look at the values not corresponding to the thinnest location within 5 millimeter zone, then you are depending on the best fit toric ellipsoid. If you are depending on the best fit sphere, you have to look at the value corresponding to the thinnest location, whatever the values around it are, no matter. Okay? Okay. Now for the first question, I'm going to ask you a question. Now, those who say there is nothing called form frost keratoconus, okay, what they define, this entity which has abnormal curvature map in the, for example, my right eye has abnormal curvature map and other maps are normal, while my left eye is keratoconus. So what they call this entity? What do they give it a name, as a name?
So shall I start with another part?
Ahmed Khalaf, yes.
Yeah, they say that instead, either there's a keratoconus patient or not. So those who are queried, they are risk to be keratoconus. But yeah.
But yeah, of course, we cannot behave with it as keratoconus. If there is just steepening on the anterior curvature and everything is fine, I cannot go and cross-link it.
Mm-hmm. Yeah, I see your point. Yeah, I'm just wanting to share that.
Yeah. Thank you very much.
Thank you. Thank you.
Naima Al-Zaliti was first to raise the hand. Naima Al-Zaliti.
Yes. Yes, Dr. Naima.
Unmute, please.
Sorry.
السلام عليكم.
عليكم السلام.
وعليكم السلام ورحمة الله وبركاته.
كيف حالك دكتور سنجاب؟ دكتورة نعيمة بنغازي.
أهلا وسهلا، تشرفنا.
كيف حالك؟ قلت لك دكتور سنجاب، معلش في السسبيشيس كيراتوكونس، لو جينا حكينا على اللي هي الريد اون ريد مثلا، لو جينا خدينا في البيكيمتري وفي الانتيريور والبستيريور اليفيشن وفي الكيرفد اللي هي الفيرست بيكتشر، كلهن كانن هوت سبوت او كورسبوندينج تو اتش اذر ان اباوت 1 to 2 ملم. فهذه ناخذها ان هي سسبيشيس لو حتى الارقام اللي عندي مثلا اندر.
أنت تستخدمي أي سيستم؟ بنتاكام؟
بنتاكام. في
أوكي.
بعض الأحيان نلقى ريد أون ريد بس الأرقام أقل في الأربعة بيكتشر، لكن الريد أون ريد نلقى الهوت سبوت في كلهن within 1 to 2 ملم. فهذا يخليني إني أنا نقول إن هذا ممكن يكون suspicious keratoconus ولا لا.
أنا ما فهمت التعبير اللي هو red on red. What do you mean by red on red?
أيوة red on red terminology يستخدموا فيه ممكن أكثر من شخص، يعني يستخدم فيه حتى الدكتور الجندي هو من إيجيبت مش مشكلة. ريد اون ريد لما تلقى الهوت سبوت بتاع البيكيمتري ماشيه مع الانتيريور ماب الاليفيشن ماب هي نفسها في اللي هي البوستيريور اليفيشن ماب هي نفسها في الكيرف، بس الارقام اندر.
اوكي. طبعا when the numbers are below the cutoff values, of course they should be considered as normal, even if you see correspondence. So the red on red means correspondence of those all together, okay?
Yes,
but usually if there is correspondence, you will find the numbers are abnormal, usually. This is the principle of the red circle, you remember, in the Cyrus. Correspondence means all together are very, very close to each other. This is why the red circle is very, very narrow.
اوكي معلش دكتور عندي كويشن تاني برضه في السسبيشيس، لو تلقى الفرق بين الابيكس اوف ذا كورنيا والثينست بوينت اكثر من 10 مايكرون لا يعني شيء هذا؟
عفوا قديما كان يعني، لكن حاليا it is very insensitive يعني خلينا نقول mark or sign, so no, don't depend on it.
وبرضه لما تجد الثينست لوكيشن في البوث ايز الفرق بيناتهم اكثر من 30 مايكرون نفس الشيء لا تعني؟
تمام. لا، هو في دراسة على الانتر اي اسيمتري. اوكي there is هي يعني انا ذكرتها في اليوتيوب في الكلام عن الكورنيال توبوغرافي وال5 minute بلس والى اخره. اذا تروحي للسنجاب اكاديمي في اليوتيوب حتشوفي انا حاطط في دراسه published inter eye asymmetry comparing both eyes in keratoconic people depending on 5 parameters including the thinnest location. If the difference is more than 12 microns, it is considered significant. 12, not 30.
Well, last question دكتور في الكيس نمبر 2 how to know ان في misalignment مش الكيس اللي حضرتك درتها في نمبر 2 ما فيش حاجه معينه تخليني اني نعرف ان هذه misalignment مش real picture.
Yeah, there is. Of course, you have to compare pupil center coordinates x and y of pupil center between right eye and left eye. If you find a big difference between y and y or x and x, then this is misalignment.
I mean ازاي كيف الواي والاكس يجي بالماينس تقصد حضرتك؟
تمام. هلا I explained this in the videos as well. So if you like, you can go to 5 minute plus and you can see.
اوكي انا عندي كويشن واجده بس خليها للمره الثانيه لان
we are out of time.
لا عارفه شكرا جزيلا يا دكتور. شكرا
حياكم الله. حياكم الله.
I think I will have one more question from Dr. Ahmed Yahya.
Thank you very much for those who arranged this amazing webinar, and thank you very much for dear Professor Dr. Mazen for step-by-step explanation. I have two questions. You said that in the sagittal map, you compare 2 points in the 4 millimeter. But if we have a steep point away from the 4 millimeter, and for example, in 5 millimeter, is it significant or not?
Yeah, it is significant, of course. And usually when you see this, let's say that if you are looking at the curvature map, magnified, 9 millimeter magnified, and you are looking at the 4 millimeter, 2 opposing points, usually they reflect the whole shape of the cornea. It's very rarely to find these two very normal and then there is a hot spot beyond the 4 millimeter. It's very, very rare. However, if you find it, it is significant. You have to look why there is this hotspot.
Okay. Second question: do you treat para-ectagial cases, or only wait and if you find a progression later on, you treat them?
Yeah, it depends actually on the corneal thickness in the para-ectasia. It depends on family history. If the other eye is not keratoconus, of course, so it is keratoconus suspect. So it depends on the thickness of the cornea and the family history. If the thickness of the cornea is critical and there is family history, then I treat, I don't wait.
Yani if the case is formifrost keratoconus, you will wait?
Now for formifrost, if because the second eye is keratoconus, I'm of course I have to follow up more, because there is keratoconus in the other eye, and we all know that keratoconus is usually bilateral, although there are documented cases and published studies about unilateral keratoconus, and the patients were followed for a long period of time, and the other eye did not develop keratoconus. However, but usually keratoconus is a bilateral disease. Now, if the formifrost has a good thickness, and the patient is in the stable age above 30, no need to treat it. We just observe. And even if the patient is in the progression age and the thickness is still good, I observe as well. But if the thickness is critical, borderline, I may interfere, yes.
Thank you very much, thank you.
Pleasure.
Thank you very much, Dr. Mazen, for this nice topic and for your generous time with us. Excuse me.
Thank you very much. Goodbye, everybody.
Thank you, bye-bye.